All right, let's go ahead and get started. So thank you all for logging on. Hopefully the holiday week went well. Excited to see everyone back in the hospital. For today's noon conference, we're going to be doing a Tox conference. So I used to do these on the whiteboards when we were still doing in-person conference at the U, but we're going to do one of these via the virtual whiteboard today. So the way this conference will work is we have 3 mini toxicology cases. 2 of these are fairly recent. One of these is from when I was a second-year resident. And the best thing for these conferences is for you guys to either participate in the chat, or Corey is also texting me as well right now, which I thought I had turned off. So best thing for you guys to do is participate in the chat or just shout out if you know any answers. All right, so with that being said, if you guys want to put into the chat right now which case you want to start with, case 1, case 2, or case 3. So we got Amelia with explosions. All right, so we need someone to, it looks like we're going to start with 3 because Amelia said explosions and Ace said 3 as well. All right, so let's go to case 3. So if we scroll down to case 3 over here, case 3 is going to be a case from when I was second year at Denver Health. And so this person's chief complaint, they are an 89-year-old woman coming in with hallucinations. So I'm going to give you guys a little brief history and then we'll get into her toxicology case. So she's an 89-year-old woman with hallucinations. She has a history of blindness and chronic back pain. 5 days ago, she had something called an Ahmed valve procedure, which is a procedure that ophtho does where they essentially, I think, put in some sort of valve to help with glaucoma in the eye. She has this procedure 5 days ago and gets discharged home. It was an outpatient procedure. Approximately 24 hours after returning home, her daughter reports that even though she's blind, she says she is seeing things. She reports seeing bats, cows, and chicks, like small chickens, flying around her head, as well as scenes of a burning village in Mexico, which she says is the place she grew up. So she presents to the Denver Health ED. In the ED, her vitals, she's afebrile, heart rate is normal, her blood pressure is within normal limits, and she's satting well on room air. On exam, I'll just tell you right now, the only thing abnormal is she is actively hallucinating with you in the room. She's swatting at flies around her head and keeps pointing at things and saying they are on fire. However, when you ask her how she's feeling, she's able to momentarily stop swatting at the flies and talk to you with an interpreter and say that she feels okay, and she denies all other symptoms outside of her hallucinations. So in the chat right now, what additional questions do you have for this patient and for the patient's family member? You're standing in the room, she's actively hallucinating, and you've got this history. Awesome. So Ace says they want to do a med rec. Perfect. And Ace, what are you, if you want to put in the chat, what are you looking for on that med rec? Connor asked for psych history. Perfect. Awesome. So someone asked about anticholinergic, and I apologize because I don't know who Jay Chang is, but why are you concerned about anticholinergics in this person? And then Jake says he's interested in something called the Charles Bonnet syndrome. Perfect. And then because hallucinations from cards. Awesome. All right. And Ace is saying new meds, opioids, centrally acting meds, anticholinergic meds. Perfect. All right. So you guys get a med rec done. And in her med rec, she's taking Percocet for chronic back pain. She's been on that for quite some time. And then after the Ahmed valve procedure, she was put on Atropine Eye Drops and prednisolone eye drops. She's never taken either of these medications before. She started them both day of procedure. So I think you guys were all sort of right on. You guys said hallucinations, looking about anticholinergic. Bill put in Mad as a Hatter. And so this is going to be a pretty easy question, but of these medicines, which one of these is most concerning for a toxidrome? Awesome. So Ace is saying atropine. Perfect. So the atropine eye drops were most concerning for a toxidrome. And so Bill already put in part of it, which is mad as a hatter, but I want everyone on the call just to put in one additional statement from that sort of lyrical rhyme that describes anticholinergic toxicity. So dry as a bone, fast as a rabbit, mad as a hatter, perfect, blind as a bat. Great, that's awesome. So you guys are clearly on top of anticholinergic toxicity. And so one of the really interesting things here is this person actually did have anticholinergic toxicity from the atropine eye drops. We stopped her atropine, and her visual hallucinations stopped within about 12 hours. So has anyone here ever seen anticholinergic toxicity from atropine eye drops? So one of the questions that I asked when I was admitting this patient is, what exactly do atropine eye drops do? What is their bioavailability? How does this compare to getting systemic atropine? It turns out atropine eye drops, essentially when you give someone an atropine eye drop, one drop is equal to about 0.5 milligrams of atropine, with a bioavailability of somewhere between about 64%, give or take 25%. So depending on the person and depending on sort of what operation they've had, that drop in the eye can give them anywhere from 0.2 to 0.5 milligrams of atropine. And sort of the crazy thing about this is also our ACLS dose. And so depending on your patient, you may be giving them an ACLS dose of atropine via the eye, and it has pretty good systemic bioavailability. And so one of the really interesting parts about this, and the thing that we all focused on when we admitted her, is how is a blind person having a hallucination? And I am actually shocked that Jake Hershey knew about this. But Jake, if your microphone is working, can you explain to us what the Charles Bonnet syndrome is? See if Jake's microphone is working here. Jake's microphone might not be working. But essentially the Charles Bonnet syndrome is a syndrome in which people who have blindness sort of develop these hallucinations. And this was actually also described by Miller and Fisher, the ones who are responsible for the Guillain-Barré variant. They describe this as well, but the Charles Bonnet syndrome, essentially, the simplistic way of thinking about it is people who have blindness develop hallucinations. And so they are sort of vividly seeing things, even though they are blind. And so if you dig into sort of atropine eye drops and atropine neurotoxicity a little bit more, this person's sort of toxidrome and syndromes were actually pretty consistent. And so if you go back to like the 1940s to 1960s, a lot of these, oh, Ed Chan is telling me Miller Fisher is one person. That is actually, I did not know that. Thank you, Dr. Chan, for pointing that out. So even more impressive that they had such an impressive career, because it's not two people, it is one person. So the atropine neurotoxicity pretty commonly described as sort of vivid pastoral scenes. And so people have either these really vivid images of, burning, of landscapes, of sort of animals, cows, things like that. And it's pretty persistent throughout the literature for whatever reason. And so this was just sort of a good case of not anchoring. As a sort of elderly person, she had a lot of reasons to be delirious and have hallucinations, but doing that really good med rec, seeing she had an anticholinergic, stopping the anticholinergic and seeing what happened. And ultimately this woman did significantly better, and she was discharged within 24 hours of having her atropine eye drops stopped. Any questions from people logged on about atropine neurotoxicity?
Danny, I just want you to know I got kicked off, and then I came back to saying this is Charles Bonnet, so I could not be happier.
Awesome. If Jake ever logs back on, I'm going to ask him to explain Charles Bonnet, because I'm still shocked he was able to get that.
I am back on, Danny.
So you guys have checked off number 3 here. So you've got 2 and 1 left. In the chat, people throw in which case you want to do next. Any takers on a choice here? Bill is saying 1, or Ace and Bill are saying 1, so we'll go with number 1. Perfect. All right, so case one. So does anyone know who that gentleman in the image there is, first of all? All right, well, we will get to him because he ends up being the first one to ever describe this phenomenon. All right, so case two. So we have got a 30-year-old woman coming in with agonal breathing who is also unresponsive. So this woman's brief history, EMS was called to her home, and before EMS could get there, the family put her in a car and drove her to the hospital and left her sort of outside the ED, agonal breathing and unresponsive. Per the family, she had taken some unknown drug that evening and had a prior history of opiate use disorder. The family also thinks that she has a history of pill use, and they think she may have tried or gotten a new set of pills that day. Her vitals in the ED, she is afebrile. Her heart rate is 92 over 40. She's got a heart rate of 90, blood pressure 92 over 40, heart rate of 98. She is setting 100% on a non-rebreather at 15 liters. This was put on in the triage area, and she has got a respiratory rate of 6. On exam, she has got a GCS of 3. She is unresponsive, and she is not protecting her airway per the ED admission note. All right. So I'll also give you this one. Her pupils are also pinpoint. So I think most of you would probably have asked about that. Okay. So you've got this exam. You're standing next to the bedside for this person. What do you guys want to do? All right. A says Narcan. Perfect. That's great. So that should be like your go-to answer. You know, she's got the low respiratory rate. She has a GCS of 3. This person is critically ill, presumably from an opiate overdose. And you just said the right thing. You want to give them Narcan. Ace, how do you want to administer the Narcan? So Ariana says she wants to dilute it. Great. Anyone else have thoughts on that? Awesome. So Ariana is actually great. So Sneha says bolus, then drip. Perfect. So there are basically two ways to go about this. So sort of the decision tree, I think, Ariana asking if she has an airway, Ace, does she have access, can do intranasal, perfect. And so the sort of the big decision tree here, the first thing you can think about is access. And so just like Ace said, if they have access, IV is preferred because it gets better systemic absorption, it gets in, starts to work faster. If they don't have IV access, then intranasal is going to be your next best go-to, or IM. So intranasal, it's a little bit slower than IM, but it's the easiest to administer. You just have to put the thing in the nose and then press down, essentially. So I'll tell you that this person ended up not having IV access, so she gets intranasal to start. So that's your first question. The next question you have to answer is sort of level of sickness or sort of level of acuity. And so if this person is critically ill, meaning they're not protecting their airway, their GCS is this low, you want to give the entire dose. If this person is sort of less ill, meaning they're perhaps protecting their airway, they are still breathing, this is not a cardiac arrest or pericode situation, like Ariana said, you want to dilute it. And for people in the chat, why do we want to dilute this for our less critically ill patients? Great. So ACE says less risk of precipitate withdrawal. Perfect. And so depending on how chronic a user someone is, you can precipitate withdrawal if you give the entire 0.4 Narcan dose. And so it's a really good idea if this person is not critically ill, if they're still protecting their airway, to dilute out your Narcan and give it. And so when I was an intern, I was actually, I'm not sure if other people experience this, but I was also often frequently confused as to how to actually dilute out the Narcan and to sort of what to tell our nursing colleagues when this happens. So I know that's a lot to type, so I'm not going to ask anyone to type that. But if any of the seniors or interns who have done this so far want to talk via the audio and tell us how you dilute out the Narcan, that would be perfect. I'm going to draw this while you guys are talking if no one talks. All All right. Bill, so take a 10 cc syringe, push out 1 cc, then fill the rest with 0.4 Narcan. Awesome. So Bill's right. So Narcan, you've got 1 ml of Narcan at the bottom of the Narcan container. And then the next thing you want to do is you want to grab your 10 cc flush. So this is a 10 cc NS flush. And what you want to do is you want to take this 1 cc here and you want to put that in the trash. And then you draw up the rest. And so essentially you go from 0.4 milligrams of Narcan to 0.04 milligrams of Narcan per 1 ml. And so then when you're standing in the room, you can ask the nurse to give it 1 ml or 2 mLs at a time. And you wait essentially 15 to 30 seconds after each dose to see if there's any effect. And this is a really good idea for our patients who are chronic opiate users because there's less chance of precipitating withdrawal. It's sort of a more smooth transition out of the critical illness or that sort of opiate-induced obtundation. And it's pretty easy to accomplish as well. And most, if not all of the nurses in our hospital will be very comfortable doing this for you if you ask them. All right. So this lady, she gets the full dose because she did not have IV access and she was critically ill. And she wakes up and starts protecting her airway. So she's not intubated. However, following all of that, she then becomes hypoxic about 10 to 15 minutes later, satting about 86% on 3 liters with a slightly increased work of breathing. So the ED team, she's still down there, does an excellent job and grabs a chest x-ray on this person. And here it is. So I'll give about 15 to 20 seconds for people to take a look at this. And then if one person wants to be brave enough to read this x-ray, that would be fantastic. If not, I might ask Dr. Albert or Dr. Chan to give their expert read. All right, any takers on reading this chest x-ray? In that case, I am gonna ask Dr. Albert or Dr. Chan, do you guys have thoughts on this chest x-ray? Dr. Albert might have logged off. Dr. Chan, do you have thoughts on this chest x-ray? Sneha. Oh, there we go. Chan, possible retrocardiac opacification. Perfect. Jumps in to save the day. All right. So Dr. Chan thinks possible retrocardiac opacification right there, which is sort of exactly what the ED team thought. And so the ED team thought maybe there was a retrocardiac opacification. And then the other thing they were looking at was sort of this area here, this area here, this and this. And they thought maybe there was also a little bit of hilar fullness. And they thought maybe some hilar fullness and maybe some pulmonary vascular congestion as well. But sort of big picture, they looked at this and they didn't see anything like really super convincing for a pneumonia, for clear flash pulmonary edema or anything like that. So does anyone know why this person may have become hypoxic? I guess a better way to put that is, what is one of the rarer side effects of Narcan administration? Put another way, why might this person have increased pulmonary vascular congestion after Narcan administration? Is it okay if you don't know? Yeah, Bill says so. Bill says flash pulmonary edema, which is great. So not technically flash pulmonary edema, but Narcan itself and naloxone is associated with pulmonary edema. And so one of naloxone's well-documented side effects is pulmonary edema. And actually the first person to ever document this was William Osler, who is the picture up top in 1880. So not necessarily naloxone because we didn't have naloxone then, but he noticed that opiate users were developing pulmonary edema. And so opiate use itself is associated with it, but naloxone, now that we also have that, is also associated with pulmonary edema. So how does naloxone do that? And there's basically sort of two big theorized mechanisms. So one is you get a lot of sympathetic activity when you give the Narcan. And so Narcan causes these people to have a sympathetic surge, which causes some capillary dilation, fluid rushes in, you wave your hands, they get pulmonary edema. The other one, which I think is a little bit more physiologically sound, is you get something called negative pressure NP pulmonary edema. And so how this happens is the person essentially gets their respiratory drive back first, but their glottis remains closed. And so these people take a huge breath against a closed glottis, causing a lot more negative intrathoracic pressure, and they get a backup of fluid. Again, I think that's kind of a confusing thing to hear. And so how does that work, and what's sort of an easy way to remember that? And so if we look at this person's chest x-ray, I'm going to draw sort of their heart contour right here. And so if we draw a line down, this is the LV over here, this is the RV, aortic valve, and aortic kind of comes out like this. Okay, so what happens if we draw sort of the wall of the LV, we always think about a equation for the transmural pressure, which helps us sort of determine afterload. So your transmural pressure is equal to your LV systolic blood pressure minus your intrathoracic pressure. And Dr. Albert brought up on a recruitment call last week that your intrathoracic pressure is negative. And so when these people have sort of a respiratory drive, but a closed glottis up here, they generate a huge negative intrathoracic pressure with that closed glottis. And so what happens is, let's say her LV systolic pressure is 90, her normal negative intrathoracic pressure is 5. This ultimately comes out to a transmural pressure of 95. If you generate a larger negative intrathoracic pressure to overcome that closed glottis, then what happens is, say this is now negative 15, you get a negative minus a negative 15, you end up getting something, like 105. These are all sort of fictional numbers. And so you get a larger transmural pressure, which equates to increased afterload. So that increased afterload plus more venous return from taking that large breath causes fluid to fluff out into your interstitium and causes this negative pressure pulmonary edema. And Dr. Chan brings up a great point that negative pressure pulmonary edema more common in obese individuals post-operatively. And this woman was obese as well, which you can sort of it's sort of hinted at in her chest x-ray. And so being obese is a risk factor for this. Having an existing upper airway obstruction is a risk factor for this, and having any sort of prior anatomic abnormality as well. So it was presumed that this woman had negative pressure pulmonary edema from her Narcan administration. She was put on non-invasive positive pressure ventilation, and within about an hour or so, she was sort of weaned back to room air. And so the treatment for this is still supportive, but just a good side effect to be aware of if you're going to push that entire bolus of Narcan and your patient becomes hypoxic soon after. Any questions about Narcan, its administration, how we dilute it, or sort of this rare side effect of Narcan-induced pulmonary edema?
Danny, can I just jump in and say, I saw this as well. It was actually in a young individual pretty recently. And their chest x-ray looked actually very similar to some of the COVID patients.
So that leaves us with one case to go. We finished up Mr. Osler here. Similar to Miller Fisher, had quite an accomplished career. Only one person. Makes me feel useless a lot of the time. All right, so let's talk about amlodipine. This picture is not a secret. This person is going to have amlodipine toxicity. And the reason I chose this case is, I was moonlighting, and there's a person in the DH MICU who just had this, but I think all of our hospitals see this usually once a month or so, and it's a good thing to be aware of. So this person, they come in with an intentional overdose of amlodipine. So this person took 5 milligrams of amlodipine and 75 tabs. There were some co-administrations there, but this was sort of the one that was the most concerning. They took it about 4 hours before arrival. Their initial vitals, they were afebrile 36.8, heart rate was 105. They were 94/62 on initial check, setting 96% on room air. On exam, the ED attending commented that they were sleepy, but okay perfusion. So I want you all to pretend that you are the DH admitting resident or the DH admitting intern, and you get this call from the ED that this person is getting transferred up to the MICU for a calcium channel blocker overdose. And in the chat, I want you guys to throw in sort of how you think about triaging this person, what therapies they might need, et cetera. Give it about 20 more seconds here. Awesome. So Ace is saying insulin. Perfect. So insulin's going to definitely be one of the things we talk about. Bill saying fluids, calcium, and pressors. Perfect. So Bill and the ACE team are on top of things. So what Bill and the ACE team are talking about is there's sort of this like stepwise approach to thinking about a calcium channel blocker overdose. And so if you draw out these steps here, going from sort of best case scenario down here to worst case scenario up here. The first thing that we want to start out, which is what Bill said, is fluid. And Dr. Chan brings up intralipids, which is a perfect thought. So the first thing Bill said was fluids. So fluids is going to be your best case scenario. So if this person comes in, they've taken just a little bit of fluids, they have peripheral vasodilation, but they've taken just a little bit of amlodipine, they have peripheral vasodilation, they may be able to get by with just IV fluids. But for an overdose this bad, they probably won't be able to. So if fluids don't work, we step up next, like Bill said, to vasopressors. And I want you guys to put in the chat what dose of vasopressor you think these people might need, or is there, I guess, a true, false question. True, there is a max to the vasopressor. False, well, actually doesn't make any sense. That doesn't make any sense at all. So I guess my question is, what do you guys think the max dose vasopressor is for this person? So Chief 101 is don't ask a terrible question. And that was an absolutely awful question. But Ace says no max, which is great. Yeah, so there is no max dose. So you can do norepi or epi with sort of no upper limit. And, you know, I feel like it's interesting to hear no upper limit, but then you actually look at what no upper limit means and it's wild. So Toxicology writes some of the best notes. And so what Toxicology said is you can go to a norepi dose of 100 micrograms per minute or an epi dose of 150 micrograms per minute. And so I think what some of you are probably thinking right now is like, what is that in context, right? Because we do micrograms per minute, micrograms per kilogram per minute. And so a typical starting dose for norepinephrine with our usual stuff is about 3.5 micrograms per minute. That's that 0.05 micrograms per kilogram per minute. And a typical starting epi dose for a 70 kilogram person is about 7 micrograms per minute. So in both cases, you are using roughly like 20 to 30 times sort of the initial starting dose for these people. And there's some toxicology data that suggests that there aren't as many adverse events if you have no upper limit. And so you can basically just keep titrating with our sort of normal goal of keeping their MAP in that sort of 65 to 70 range. So the next thing that Bill brought up is calcium, which is a great thought. And so calcium is a temporizing measure. And so it temporarily works. And most of the time, these people will get a large dose of calcium while they're sort of getting their initial vasopressors. But more often than not, like the ACE team was referring to, vasopressors and fluids don't do it. And so we get to something called HIET, which stands for high insulin euglycemic therapy. And so I want you, if anyone knows the answer to this now, in the chat, throw in how you would dose this person's insulin. So there's a starting dose, and then there is sort of a maintenance dose. Ace is saying 10 units per kilogram per hour, and then Jake is saying I think it's something horrifying. Yeah, so both of those are correct. So it is both horrifying and it is 10 is sort of that upper limit. So the first thing you want to do, sort of similar to a DKA patient, is you want to give them sort of 1 unit per kilogram of regular insulin in a bolus, and that's upfront. Bill's exactly correct. And then the next thing you want to do is you want to start a drip, and that drip is basically 1 to 10 units per kilogram per hour, titrating it for a MAP goal of 65 to 70. And so I think the really confusing thing about this is how on earth do we titrate insulin for a MAP goal? And Dr. Chan, I will get to that one in just a second. So how do we titrate insulin for a MAP goal? So insulin at doses this high functions as both an inotrope and a chronotrope, but it takes about 15 to 45 minutes to do that. And so while you are titrating all of these medicines, you have to make sure that they're still perfusing with your vasopressors. But once you do that, you titrate for that MAP goal of 65 to 70, and you're doing this sort of with the close eye of toxicology. And then, Dr. Chan brings up a good point. So the glucose ready. So while you're doing both of these things, you have to be giving them both D50 amps to start. And then these people will often need either a D5 or D10 infusion to make sure that that blood glucose is greater than 100. And that's the euglycemic part of the high dose insulin therapy. Dr. Chan asked about glucagon. So glucagon for beta blockers sort of functions kind of similar to calcium, in which it's a temporizing measure, but ultimately for beta blocker overdose, people will get a tachyphylaxis to it and they'll feel terrible. And so it only works for, I think when I looked at it, it only works for like anywhere from like the 4 to 24 hour range before ultimately, if they took enough, these people will need the high dose insulin therapy. And so just to review so far, so you start with fluids, that probably won't work. You put them on vasopressors, you cross your fingers, you say a prayer to whatever deity you're feeling closest to that day. But oftentimes these people get to that high dose insulin therapy. So what happens then if we have done high dose insulin therapy and this person is still crashing and still hypotensive? What happens next? Throw in the chat either what service you want to call, what therapy you'd like to give. So A says call Tox, perfect. Yeah, so at this point, Tox might be standing at the bedside with you, which is great. Connor and Bill are both saying ECMO, which is great. So these people will often, if they don't have other organ failure, will get an ECMO consult. And the ECMO you're looking for here is VA because the heart's the problem. And so you want VA. Cardiology is saying methylene blue as well. Methylene blue is sort of one of our last line vasopressors. It sort of scavenges free radicals. I won't pretend to know what that means, but that's what it does. And then the very last thing is intralipid as well. And so intralipid can be tried if it's a lipophilic medication to help sort of clear it from the body. And Tox will be the one who helps you determine sort of the order of all of these things. I will also say in this person's case, unfortunately, this person passed away in the last 24 hours at Denver Health. But the other thing that Tox had talked about was something called a cytosorb, which is basically a membrane that you can hook onto a blood pump. So onto a CRRT filter in which you can basically take out substances from the blood, essentially clean the blood through a membrane. It sounds like there's a FDA sort of emergency use authorization for calcium channel blockers in this cytosorb product. But more often than not, if these people are this sick, they're going to need ECMO or perhaps intralipid, depending on which toxicologist you're talking to. So just to review, calcium channel blocker overdose, we start with fluids, vasopressors at no max dose, high dose insulin therapy, and in a worst case scenario, we're calling our cardiothoracic surgery friends. All right. And I will say, just as a sort of interesting end note to this, unfortunately, the person passed away. Prior to passing away, they were receiving norepinephrine wide open. So they were getting 975 mLs of norepi per hour, which I did the calculation, came out to a dose of 1,066 micrograms per minute. And they were receiving basically 2 bags, a liter of norepi per hour, which is never a situation that you want to be in. All right. So just to zoom out here, so that was the toxicology case. We did 3 mini cases today. So we talked about William Osler and naloxone. Ed Chan's question here, is there any role for bowel decontamination? Yeah, great question, Dr. Chan. And so if they come in early enough and you think their bowel still has the medication in it, you can try the activated charcoal and decontamination. I believe in this person's case, they had sort of gone through that window. I think they might have even tried it anyway, and there was just no pills left. And the other thing that Dr. Chan brings up is there's sort of a stuttering course to calcium channel blocker overdose. It takes a long time to absorb that many pills from the gut. And so these people often have a period where they sort of appear to improve because they haven't absorbed the rest of the amlodipine or the rest of the calcium channel blocker. And then they fall off a cliff once the sort of the rest of the pill burden soaks in. All right, so just as a recap, talked about William Osler and his naloxone-induced pulmonary edema, a rare side effect that we should be aware of. We talked about high-dose insulin therapy and calcium channel blocker overdose, which both of our sort of DH and UCH ICUs have had a patient with this either now or in the last 48 hours. And then we had Jay Kershey out of nowhere talk about the Charles Bonet syndrome and anticholinergic toxicity from Atropine Eye Drops. And so just a good reminder to do a nice med rec on all of our patients, especially after procedures that we are less familiar with, i.e. optho procedures. And that's it. Thank you all for participating. Hopefully that was helpful. And if anyone has any questions, feel free to shoot me a text or email.